Today, it's my pleasure to welcome Dr. Samir Ansari as our speaker. Dr. Ansari currently serves as a professor and section chief of interventional neuroradiology at the Northwestern University Feinberg School of Medicine and the Northwestern Memorial Hospital in Chicago. Dr. Ansari completed his medical training in diagnostic radiology at the University of Illinois, followed by a diagnostic and interventional neuroradiology fellowship at University of Michigan, Ann Arbor. Dr. Ansari specializes in minimally invasive endovascular procedures in the brain and spine. He remains active in clinical and basic science research that focus on MR imaging as well as neurovascular pathologies. In addition, he has clinical research interests in acute ischemic stroke thrombectomies and embolization of intracranial aneurysms. He has published widely in peer-reviewed articles on cerebrovascular diseases. Today, we are excited for his talk on expanding indication for acute ischemic stroke thrombectomy. Thank you, Dr. Ansari, for joining us. We're excited for your talk. You may share your screen.
Thank you much. Yeah, it's an honor to be here, and thank you for the invitation. Hopefully you can see my screen there.
That looks great.
Great. So yeah, my talk today was on the expanding indications for acute stroke thrombectomy. It's been almost 10 years of just an immense amount of achievement and evolving practice really in this revolution of stroke thrombectomy. There's a lot here, so bear with me, but hopefully it'll be educational and informative. Only disclosures, we did participate in several of the randomized controlled trials and studies related to the stroke thrombectomy development over the last several years. We're fortunate to have participating in Diffuse 3 and currently Precise and Tesla, which was just released this last week, and hopefully go through some of that data if time allows. And then I work on various DSMBs for industry studies on stroke thrombectomy devices. Ischemic stroke, as you well know, is a huge burden on our healthcare system, about 800,000 strokes in North America every year. It was, quite a leading cause of even mortality, although that has improved from being the third to the fifth leading cause of death but still one of the most common life-threatening neurological diseases. And it's probably due to, we'd like to believe it's our interventions, but more likely all of the immense medical management and chronic stroke prevention and rehabilitation that we've seen in this field that has concomitantly developed over the last 20 years. But it still remains the most common cause of long-term disability, significant human and economic cost to the U.S., probably more than $60 billion annually now. And in the past, unfortunately, there was really a lot of nihilism associated with stroke intervention. It was limited to the post-stroke care rehabilitation. So it wasn't until 1995 with the landmark and INDS trials that suggested the IVTPA, or confirmed that IVTPA would be, really associated with an improved outcome and independence of about 40% versus the control arm. And that really was the first intervention we could really offer these patients. But even then, really early after the NINDS trial, there was some data that suggested that even intraarterial therapies with prourokinase for large vessel occlusions that were ineligible for IVTPA could undergo thrombolysis with fairly good efficacy rates at that time for just, intraarterial thrombolytics, 60-70%. And then the outcomes were also improved in that RCT. Unfortunately, prourokinase came off the shelf, and we would be delayed until we would really be able to prove the value of endovascular therapy for some time. The IVTPA window expanded to 4.5 hours with the ACAS-3, and even currently, thrombolysis has continued to evolve with tenecteplase, demonstrating greater efficacy and equivalent safety to IVTPA, and that's taken over as the main thrombolytic agent. But of course, the benefits of intravenous thrombolytics is limited beyond 4.5 hours. Several meta-analyses of the RCTs demonstrated that the time-dependent efficacy really devalues over quickly, and that the eligibility is typically less than 10%, perhaps improving with improving stroke workflow and processes over time, but you're limited by the time window. And more importantly for our work, there's relative poor efficacy in large vessel occlusions. Once we start seeing proximal MCA to IC occlusions, that efficacy is reduced to 10 to 30%. And these eligible LVO large vessel occlusion populations are certainly a subcomponent of ischemic stroke, probably less than 20%, but these are, of course, the most severe strokes, those that cause the most very high mortality, morbidity, and long-term disabilities with a disproportionate amount of the healthcare cost. It was really the early IMS investigators that started to study IA therapies, whether it was IA thrombolytics or early generation retriever devices, such as the Mercy retriever, and first generation or second generation aspiration catheter devices, which evolved, I think, by 2012 to what we have now, perhaps more improved versions of stent retrievers, balloon flow arrest guide catheters, and large bore aspiration techniques. And so the field, I remember distinctly in 2013, took somewhat of a setback where 3 randomized controlled trials were really presented that demonstrated no clinical benefit of endovascular therapy. And that was, kind of I think a very important moment, because it taught us some valuable lessons on selection, trial design failures, but it also kind of moved the field towards something we would tailor our trials towards, which was really selecting patients very carefully for the next 10 years. And it's only now that we see that perhaps we may have over-selected. And that was some things that are now completely common sense for us. Patients have to have severe symptoms, high NI stroke scales. You have to confirm large vessel occlusions on angiographic imaging. The reperfusion has to be done, efficaciously with modern devices that have to optimize time to treatment, workflow, and then advanced imaging selection, or selecting patients with, potentially ischemic salvageable tissue versus futile infarcted tissue. At least that was what the field would move towards. And it was very rapidly afterwards that 5 randomized controlled trials and 2 others in Europe demonstrated the vast benefit of endovascular thrombectomy and anterior circulation ischemic stroke due to a large vessel occlusion. This was all in the early interventional time window within 6 hours, and really established level 1A evidence for this being the standard of care treatment. Really a monumental event, 2015, with Mr. Clean, Revasc, Swift, Prime, Escape, and Extend IA. And I think, instead of going through all that data, this fairly old data now, the Hermes meta-analysis, I think, shows a nice conglomerate of what those trials show. This was almost 1,300 patients with high NI stroke scales, median 17, 18, with ICA M1 occlusions mostly, some M2 cohorts, and fairly good reperfusion rates for that time with the modern devices. Again, early presentations other than Escape, which was up to 12 hours, and with rapid interventions and workflow for that early time period in 2015, with fairly mixed advanced imaging tissue selection strategies, which we'll talk about in a little bit. But really, the outcomes were amazing. I mean, it was probably one of the most powerful interventions we have in medicine. Is kind of, now when we look back, how did it take us, from PROACT 2, almost 15 plus years to figure this out. But, for every 2 to 3 patients that undergo thrombectomy, 1 will be independent. And that corresponds to almost 50%, at least in this highly selected trials, of patients who were independent at 90 days. And with early neurological improvement, almost half of those patients at 24 hours, with no real cost for, increasing symptomatic hemorrhage and even some mortality benefit in some of the trials. Furthermore, I think from that meta-analysis, you could really see that there were a lot of other subgroups that were identified that could be studied, or at least that there was suggestion that benefit for endovascular thrombectomy persisted, whether it was age, elderly patients, whether it was more moderate core infarcts, aspect 6 to 8, whether it was late presenters. Could we expand this window? That would be a very strong theme that would take over in how these trials would be developed, with later randomization patients still demonstrating a benefit, and in tandem ICA, MCA occlusions also demonstrating significant benefit. And it's clear that, advanced imaging, played a critical role in the success of these trials. 4 out of the 5 used also tissue criteria. Obviously, there had to be some LVO documented on angiographic imaging, but it was really some of these semi-quantitative tissue selection strategies that we started to be able to identify in small core infarcts, large salvageable ischemic tissue, the penumbra, and really using various techniques in the 4 trials, started to establish criteria for who to choose and to demonstrate that benefit or endovascular therapy. You may all know aspects is the simplest score that can be done with CT or even MR diffusion weighted imaging biomarker for core infarct volume. It's more crude, 10-point scale for ischemic or infarction versus normal. So 10 is normal, 0 is complete infarction. The ICMC distribution of 6 cortical, subganglionic, and supraganglionic regions, as well as 4 basal ganglia regions. The ESCAPE Alberta group really pushed for multi-phase CTA. That was another technique that looked for poor collaterals using serial CTA imaging and seeing if collaterals could augment the distribution in the 2nd or 3rd phase as a direct corresponder of core infarct volume and salvageable tissue. This is a patient showing nice 2-phase delay that really corresponded with very poor collaterals, demonstrating a core infarct in that region of fairly poor collaterals in the right MCA distribution. The rapid investigators from Stanford and the diffuse investigators were really studying at this time in CT perfusion, MR diffusion perfusion mismatches to have some type of standardized post-processing technique that could overcome some of the limitations in arterial transit time delays and the role of collaterals, and how to quantify specific thresholds that would accurately predict the core infarct volume. Obviously, diffusion does that very nicely, but using CT perfusion techniques, that has to be done with relative cerebral blood flow values, and then using a Tmax type of transit time elevation to recognize the penumbra with a subtraction of the core infarct volume. Now, if you looked at these early interventional trials, those that demonstrated the best clinical outcomes compared to the, let's say, Mr. Clean or even some of the IMS and early failed trials, they not only had very high reperfusion rates and fairly early symptom onset to reperfusion times, but they were also demonstrating those trials that had most advanced imaging tissue selection. And so the thought really came out that could we use this advanced imaging to extend the time window? Could we extend it, from a 6-hour window to 12 hours, 16 hours, 24 hours? And we would see that this would really play a role in the future development of DAWN and diffuse 3 trials. The time versus tissue selection, as we mentioned, the IVTPA window rapidly falls at 4.5 hours. But we could see even from the first trial, Mr. Clean, that the mechanical thrombectomy window lasted at least up to 6 to 8 hours, and it was thought that this was attributed to differences in resistance to ischemia from large versus small vessel occlusions, because obviously with large vessel occlusions, you have the ability of the circle of Willis and more importantly, the peel collaterals to augment that area, and delay the infarction in that setting. We had done an interesting canine middle cerebral artery occlusion model with the University of Chicago, and showing that you could really see that the rates of infarct growth and final infarct volumes were very animal specific, meaning that if you and could be correlated with directly to the Peel collateral scoring of those dogs. And so this really gave us further impetus to think that core infarct volumes plus collaterals could be estimated based on maybe a basic CT MR aspect score, obviously diffusion perfusion or CT perfusion imaging, the multi-phase CTA collateral scoring that was being proposed by the Alberta group, and could we really optimize the inclusion exclusion of patients, improving the outcomes in these trials, maybe identify cohorts that could benefit in the extended window or the wake-up strokes, but we didn't really know when their stroke occurred. And could we identify those that were really progressing early with poor collaterals that were very time sensitive versus those that may be time insensitive. Extended time window, this came very quickly. So that was 2015. By 2018, we started to see both Dawn and I won't go through both of the trials, but at least for Diffuse 3 and Dawn, I'll go through it in a bit. These were about 200 patients in each of these studies. Both were halted very early in an interim analysis, and they were, again, focused on ICM1 occlusions, anterior circulation stroke, high revascularization times. Last known well was about 16 hours, from about 6 to 16 hours in Diffuse 3, up to 24 hours in Dawn. And they really both used diffusion perfusion or CT perfusion techniques to estimate core infarct volumes. Had to be about less than 70 cc's in Diffuse 3, about 50 cc's was the maximum in Dawn. And Diffuse 3 also used the penumbra or a mismatch ratio, that you had to have some amount of salvageable tissue on top of having a low core infarct volume. Now, although their thresholds were about 70 cc's, you can see that only about 25% really had infarct volumes of about 26 to 70 cc's. So still relatively small core patients that were being selected in the extended time windows. Again, it was phenomenal that even in this extended time window, you could see outcomes such as this. Both Dawn and Diffuse had very similar outcomes, almost 45% independence at 90 days. Infarct volumes were inhibited, and no real cost with symptomatic intracranial hemorrhage. Mortality was actually statistically or borderline statistically improved with interventional therapy. And number needed to treat a little bit lower, 3 to 4 patients for everyone, but still quite a striking intervention, and obviously leading to further level 1A evidence for stroke thrombectomy of these small core patients with selection in the 24-hour window. These effects persisted across all subgroups, whether they were Dawn eligible or ineligible patients, meaning that if they had infarct volumes extending up to 70 cc's, there was still significant benefit. So I think the problem at this point was how come we were able to see so much anterior circulation benefit with selection, of course, but posterior circulation stroke thrombectomy of vertebrovascular occlusions, which is, of course, a smaller component of large vessel stroke, but associated with such greater morbidity and mortality that it would seem that it would be much easier to demonstrate a benefit of endovascular therapy in that cohort. And but even as late as 2022, there were a few randomized controlled trials, BASICS and BEST, one European, one Chinese, somewhat limited by the methodology, perhaps in the trials, but both failed to demonstrate any benefit of endovascular thrombectomy. And it wasn't until just shortly after that 2 Chinese trials. I won't go through both of them, but I'll go through at least the second one. One was Attention and one was Baosh. Both randomized patients 1-to-1 or 2-to-1, and for early window in Attention, and Baosh extended that window from 6 to 24 hours for vertebral basal artery occlusions. But they did use some tissue selection. And so these were patients with, high, obviously median 20 NIH stroke scales, vertebral occlusions presenting in 0 to 12 or 6 to 24 hours. But they did use some, what's called a posterior circulation aspects, which some may not be, used to calculating, and then also what's termed a Pons midbrain index. And I'll go through that with you in just a little bit. But again, both trials, very similar outcomes, almost, in vertebral occlusions, posterior circulation stroke, I think good functional outcomes, or at least nearly functional outcomes. MRS 0 to 3 is typically used as the outcome in many of these studies and trials. So almost, again, 50% nearly obtaining an MRS 0 to 3, quarter having early neurological improvement. And if we use a more strict definition of functional independence of MRS 0 to 2 at 90 days, is almost 30 to 40% in both trials, demonstrating independence functionally. Now, in posterior circulation thrombectomy, we do start to see increased symptomatic intracranial hemorrhage rates. Mortality is, of course, higher, but I think that's obviously due to the baseline in the medical management, or just the high morbidity and mortality associated with these patients. And again, the effects persist across all strata, whether it's age, whether it's NIH stroke scale, criteria, randomization, early, late windows. And for quick review, the posterior circulation aspects is similarly a 10-point scale, 0 to 1 point for ischemic, image ischemia or hypoattenuation, suggesting ischemia or core infarct in bilateral thalami, occipital lobes, bilateral cerebral hemispheres, and then 2 points provided for any involvement of the midbrain and pons. The pons midbrain index is the reverse of that, where 0 is normal, and a point is provided for just each laterality of the pons or midbrain for any moderate or mild or significant attenuation, less or greater than 50%. So a pons midbrain index of 2 or less is really a small amount of ischemic change that you can see maybe in 1 or 2 territories, and that of the midbrain and pons. Basics registry, I think, provided a nice assessment of kind of thresholds that were used in these trials. If you look at the PC aspects of 6 to 10 versus the PC aspects of 0 to 5, or a midbrain index of just less than 2, you saw that with reperfusion in that registry, you could demonstrate significant benefit of having patients obtain MRS 0 to 3 over those that achieved reperfusion with a greater infarct burden in those eloquent areas of the pons midbrain. It's almost difficult to give an interventional talk without at least showing some interventional cases. So I thought I would at least show one case. This was a 86-year-old male with multiple comorbidities, vascular risk factors on anticoagulation. Interestingly, what came in unresponsive, left hemiparesis and facial droop. NIH was high at 23, not TPA candidate. It codominant vertebral arteries, had a basilar artery occlusion. You can see on the sagittal CTA here. And PC aspects score was relatively normal, nothing thalami, midbrain, pons that I could really make out, or cerebellar hemispheres. His pontine midbrain index also 0 for that matter. Now, I've always thought that it's difficult, more difficult to assess posterior circulation aspects and PMI scores in the posterior circulation, just because there's so much more white matter there. There's already some inherent hypoattenuation. There's also a lot of skull-based artifacts. So, how accurate, what is the reproducibility here versus it's not as well documented in the literature versus anterior circulation aspects. But regardless, that is what was used in the 2 positive trials. And this patient had not a lot of collateral imaging potentially that I could see from the ICAs that can often go retroactive, greatly supply the SCAs and PCA distributions in mid to distal basilar occlusions. It was a radial access, right vertebral artery access. And you know, the scoring that we use on the PONS PMI index or the posterior circular aspects, these are core infarct volumes or core infarct types of thresholds, but we're not really able to really assess for the collaterals. And so that's something I'll show you, some interesting work that's being done or a study that's being done to kind of see if the circle of Willis or PO collaterals can be accounted for, can be kind of bring about some type of assessment of the perfusion and the impending infarction versus that what we see in just more rudimentary techniques such as PC aspects, which may not be as accurate as we think. So anyway, this patient obtained, you know, TK3 perfusion, I think was a single pass and fairly early on, and had a very nice initial MR diffusion post-operatively. There you go. Had a small right thalamic infarct, but and did very well with a very low NIH stroke scale. But unfortunately, this patient did have cardioembolic etiology and sent another occlusion to his MCA, which also underwent thrombectomy and accounted for higher MRS than we would have wanted, and got discharged to rehab. The precise is what I was alluding to. This is a current multi-center observational cohort study supported by the NINDS and out of Stanford from the same rapid investigators that were looking at using CT perfusion, which is or MR perfusion, which is obviously in the current imaging workflow at many institutions, and using what's called a critical area perfusion score, where Tmax delay of more than 10 seconds. If you see that in any of the cerebellar hemispheres or anywhere in the pons or midbrain, you get a score of 1 or 2, and that 6 being, you know, the worst score possible, 0 being normal. And this was really some of the data to support this came out of a study about 100 patients looking at CAP scores with or without reperfusion, and those that had very low CAP scores, meaning that there wasn't a critical area of perfusion, had fairly good outcomes with reperfusion versus those that had, you know, very high CAP scores did not obtain much benefit from endovascular therapy. So that is something that there is being worked on to, again, use imaging, advanced imaging selection for really optimizing patient outcomes. Now, the future of thrombectomy has probably taken, I think, somewhat of a shift from this whole paradigm that was, you know, being that I've kind of shown you how we were relying heavily on advanced imaging selection. And could we have been missing something? Large core infarct thrombectomy being the most, now, how do we define large core infarct thrombectomy? I think really it's those patients that were excluded from many of these trials, those that had infarct volumes greater than 70 cc's, those that, whether that's with MR diffusion or perfusion selection, or collateral scores, those that had aspect scores, maybe not even of moderate, you know, 6, 7, but lower than 5 aspect scores. And, you know, we have a saying in radiology, for, you know, that's my background, that, you know, you're not going to see something on an imaging study unless you're really looking for something or you're previously, you know, aware of that entity. And here, even from the Hermes data, if you look back, you know, this was, of course, early time windows, and this was early intervention in 2015. You can say it was a smaller cohort, of course, 200 patients overall 1,700 patients that had very low aspect scores. And if you look, the cohort that was in aspects of 3 to 5 still demonstrated almost the same odds ratio improvement with endovascular therapy. And so, you know, were we over-selecting in these randomized control trials from the trauma of that initial MR rescue and IMS period of negative trials in 2013? And so And in fact, in 2015, there was a nice study out of Europe that looked at 105 large core infarcts that underwent endovascular therapy compared to their non or small core infarcts. These were patients. This was in the early time window, of course, as well. Diffusion, all large cores that they isolated out and looked, with logistic regression for various clinical and safety outcome measures. And what they saw was that, more than 70 cc cohort, if you were able to reperfuse those patients, then you actually demonstrate an improved clinical outcome as well as a survival benefit. Despite having higher symptomatic hemorrhage rates with perfusion in that cohort, you were still able to demonstrate an outcome and survival benefit in the 50 to 100 cc as well as the 100 150 cc infarct volume cohorts, which was very surprising. And that really has led to these 6 randomized controlled trials now being released in the last year and a half. And so some of them, varying between the time windows of inclusion versus the types of imaging selection that they've done, although they've pretty much relied on aspect score. And a few of them have utilized a correlate of CT perfusion or MR diffusion perfusion mismatch, core infarct volumes of having to be more than 50 or 70 cc's. But in general, they've used aspect scores, fairly rudimentary, and various time windows, because the thinking is, could the benefits of thrombectomy be so powerful that it could be independent of this time and tissue window? And is that because we're saving eloquent tissue rather than just the volume of salvage, or is there some other reperfusion benefit that could be providing neuroplasticity? And I'll show you some of these, not all of these trials, but the first trial was out of Japan. Again, more of an early window trial. They did include some later windows if the MR flare was negative, but these were all ICM1 occlusions. 200 patients were randomized, and this was a diffusion MR heavy study. So MR aspects of 3 to 5 is probably more of a higher CT aspects, 4 to 5, 4 to 6, because that MR is so sensitive to acute infarct, as you well know. So, but this was an early intervention, but still their core infarct volumes were, to begin with, were fairly high, probably one of the higher ones of the 3 other trials that would follow this. And then they did demonstrate both MR 0 to 3 and 0 to 2 benefit of endovascular therapy. A modest benefit, 14%. This is what 1 out of every 7 patients may be independent, but still better than the control arm. Obviously, higher hemorrhage rates and with potentially some mortality benefit, although you will see that in these large core cohorts, we're going to expect to see more hemorrhage, more mortality. The next 3 trials are kind of put together. I call these the aspects 3 to 5 trials. There was some, as I mentioned, CT perfusion, MR diffusion, angel aspects saying that it had to be more than 70 cc's. This was a Chinese trial. Select 2 being European, US trial, 352 patients that used a perfusion cohort saying that it had to be more than 50 cc's, very CT based, also with aspects 3 to 5. These were both under 24 hours, but if you look at the median times in both of these trials, they were about 9 to 10 hours. And I'll show you the Select 2 data. These were all halted as well because of the interim analysis demonstrating a significant benefit of intervention, independence of almost 20% in most of these trials compared to the control arm of 7%. And with almost a quarter demonstrating early neurological improvement. Now, although these were 24-hour inclusive studies, both the angel aspects and Select 2, as I mentioned, the median inclusion for these patients was about 8 to 9 hours, and the core infarct volumes, maximum were about 100 cc's, which was kind of the median for what we saw in the Japanese first study. So I call them more moderate to large core infarct trials, but nevertheless demonstrating significant benefit, and with the effects of endovascular therapy benefit persisting across all subgroups, whether age, higher NIH stroke scales, some cohorts more than 12 hours even, and even some lower aspect scores of 0 to 5 and higher core infarct subgroup analysis. Tension, again, one of those 3 trials that I call the aspects 3 to 5 trials, more CT based, even a smaller window, median 4 hours for inclusion. They used 12-hour time as their cutoff, and demonstrated very similar outcomes with some mortality benefit, but again, a high mortality in these patients, 40% patients going on to have mortality with large core infarcts despite endovascular therapy, but demonstrating a benefit in clinical outcomes nonetheless with endovascular treatment. Now, the latest trial, this just released this week, Tesla, for large core infarct, was a US-based 47-site trial. 300 patients randomized, again, ICM-1 inclusions, as most of these trials have been, NIH base of 6. And this time, the 24-hour window, this was probably the more inclusive trial of all the large core trials. You can start to see the median creep up 11 to 12 hours. CT aspects was even more generous, allowing a CT aspect score of 2. You can see 34% of patients in Tesla had had aspects of just 2 to 3, very larger cores. 50% of patients were randomized in that 12 to 24-hour window. Now, unfortunately, they were unable to show a primary outcome benefit on their utility-weighted MRS score at 90 days, but there was definitely a statistical significance and trend for outcome benefit at 90 days with a standard MRS 0.3 or MRS 0.2 outcome assessment in their secondary outcomes. You can see their final infarct volumes were very high, 150 plus cc's, more symptomatic intracranial hemorrhage, no significant mortality worsening, but again, 30% mortality. And then the last trial, very, interestingly enough, and pun on the word, really shows 30 sites from France and Spain that, again, also a halted study. This was even more inclusive than Tesla as far as using CT aspects of 0 to 5. But again, this is MR diffusion weighted heavy. So that could mean that the aspect scores may be a little bit higher on if you were to use CT aspects alone. And then again, here they did not use that very larger window that Tesla did, only 6.5 hours. Within 6.5 hours, they're very early progressors, early intervention for this cohort, but they were able to actually, with that early interventional time window, having almost 50+% of patients having aspects 2 or less. And so very large baseline core infarcts of 130 median cc's. They were still able to demonstrate a benefit, both MRS 0.3 and MRS 0.2 functional independence at 90 days over the baseline control population. And again, modest, percentage that you're going to have a functional independent outcome, 1 out of every maybe 9, or 8, I would say. But 30% having some significant neurological improvement, 7 days of discharge. Again, higher hemorrhage, improved mortality, but still 1/3 of patients going on to have mortality. So of all the large core thrombectomy trials, we see that there's a very consistent benefit that we can demonstrate. More modest, of course, versus small core thrombectomy, but there nonetheless. And I think, these trials will be the basis of the new AHA guidelines that will be released probably next year. And we will see that that aspects 3 to 5, large core anterior circulation stroke within 12 hours will likely be class 1 level A evidence in the standard of care. Now, in that extended time window, because the median times, and even in the 24-hour trials were more modest, I think you'll probably have a less class 2A indication. And those few trials like LAST and some of the Tesla cohort will probably need some meta-analyses to elevate that, but that's still out for probably discovery. If really very low aspect scores, very high large core infarcts can still benefit. And maybe we're starting to understand where the threshold will be, where endovascular treatment will not be beneficial, but certainly something that is quite amazing how much benefit there is from this one interventional therapy. So a lot of questions come up after these trials have come out in the last year, and one of them is, well, why are we doing advanced tissue imaging? What is really the role of it anymore? If we can just use aspects CT based, it saves time, saves cost. Well, it doesn't really save that much time. I mean, it's often in our workflow about 5 minutes. Yes, we could probably save 5 minutes, but I think there are so many benefits of advanced tissue imaging that I still am a proponent of it. I think you can diagnose large vessel occlusions, medium vessel occlusions very much easier. Yeah, it improves your stroke workflow, your recognition, your team activation. There's also diagnosis of large core much easier than aspects. You have that volume threshold that can help you make that decision. It can help you with prognosis, consenting the family, counseling them, because every patient is different. The age of the patient, pre-MRS, what family would want, and then it helps you kind of get on top of the post-procedure management, the edema to expect, the hemorrhage risk, and finally, for quality assessment, for QA, if there was a very small core and you ended up with a very large core, was it something that you did? Was it your efficacy, the safety of the procedure? So I think there's a lot of value there still. Furthermore, I think with neuro-ICU surgical management, there's a lot of concerns that the malignant edema, the hyperosmolar therapy that's being required, the hemicraniectomy that we see in 10 and 20% of these patients, and the increased hemorrhagic complication risk. This is going to have downstream impacts on neuro-ICU and care and open surgical management. And then finally, the expectations that we have to kind of reduce the immense vast benefit we've seen with acute stroke thrombectomy, that you're not going to have that number needed to treat of 2 to 3 patients anymore. It's going to be more like 5 to 7 patients for every one that you may demonstrate significant benefit. And this is what we see is you have large cores. We use a lot of dual energy CT to kind of differentiate out all the contrast staining from the hemorrhage. Here you see a little basal ganglia, maybe a small PH1 developing, or HH2 and the basal ganglia after endovascular revascularization of this ACMC occlusion. Didn't have a lot of PO collaterals accounting for the large core, and that of course went on to form a true parenchymal hematoma, malignant edema, hemicraniectomy, and obviously mortality. So if we really put all of this together, you start to see the intracranial hemorrhage and mortality. It's amazing that we in the large core trials compared to the anterior circulation trials, where there was no real cost of hemorrhage or mortality, we do start to see that an increasing symptomatic hemorrhage risk as we start to relax some of these parameters for inclusion, moving these volumes from angel aspects and select 2 from the 80 to 100 cc to more 150 cc inclusion criteria, aspects 0 to 5 or 2 to 5. Let's just we see in Tesla and last. You start to see increasing hemorrhage risk. Although there is some mortality benefit, over the control arm, there is obviously 30 to 40% of patients that will go on to have mortality, and so that should be expected, and that's mirroring actually the posterior circulation mortality that we see. And I think it's going to be, something that we have to get accustomed to, but it may be the new reality. I think future for further expanding indications for thrombectomy are going to be, some of those octogenarians and nonagenarians, those patients who have a pre-existing disability. There are several trials already going on for low NI stroke scale inclusion for thrombectomy, or medium vessel occlusion certainly will be probably the next randomized control trial data that we'll see being released from things such as the distal or escape mevo, and whether this will also demonstrate, the further application of thrombectomy remains to be seen. I think, that in conclusion, we have, probably the best evidence all within 10 years of class 1 level A evidence for anterior circulation thrombectomy within 6 hours, up to 24 hours, with small cores and some type of advanced imaging selection. Posterior circulation has also now demonstrated class 1 level of evidence B data on both in the early and late time windows for basilar thrombectomy. I think with large core infarcts, we remain what will be decided upon, but I think there's very good data within the early interventional time window with aspects 3 to 5 that we have multiple randomized controlled trials demonstrating, level 1A evidence for it becoming the standard of care. Whether that will, how that will be suggested in the late presentations from 12 to 24 hours or those with aspects even lower than 3 remains to be seen and probably will require some further studies. And we expect multiple other randomized trials to hopefully give us further insight onto expanding these indications in these other populations and cohorts we spoke about. Thank you. Take any questions.
Yeah. Thank you so much, Dr. Ansari, for this comprehensive talk and a very important topic. The floor is open now to question if there's any.
Hi, Samir. Dr. Monteith here with Cerebrovascular. Great talk, really enjoyed it. Super comprehensive and great for not only our fellows, but our whole team to kind of get the full overview. This issue of the low aspect score strokes is kind of a hot topic nationally. We have some colleagues around the country that are sort of quite cynical about the low aspect score cases, and as you mentioned, some places are not even doing perfusion imaging now, and just doing a dry CT. In terms of how you interpret or how you apply these all these trials with the large cores, poor aspects, is there anything, or what's the sort of patient that you wouldn't take for thrombectomy now? If you had an aspects of 2 in a 9-year-old left-sided MCA syndrome with an aspects of 2 or 3, are you guys taking all those patients, or who would you say no to, given that we have these outcomes?
It's a tough question. I mean, I think it's a great question because we think about that a lot. I think it's very patient specific for sure, because obviously if the MRS baseline is higher, we're not even going to offer it probably, but if let's say they're independent, they're a 90-year-old, and we just present the data, there's low likelihood that this patient's going to get back to where they were, 15%. And various families, it's very family dependent. Some families are they want to give it a shot, and some are like, this is not what our father or mother wanted, and so I think there's some value in triaging patients that way, giving them the choice, because there is going to be all the downstream consequences of this patient, within aspects of 2 undergoing thrombectomy, whether that's going to be hemorrhage or craniectomy, are they going to even go through with all of that, so that are they prepared sometimes, and the imaging selection is another way of really because aspects 2 and 3 or even 2 and 4 sometimes, it's hard to really, sometimes the CT scanning is not very, very good at if you've seen some of the outside imaging reading, I get to read some of this on some data, DSMBs, and the CT scans are not very accurate, so how can you really, so I think having that another methodology where you can really gain a little bit more confidence in speaking to the family with, what are we seeing here? How much damage really is there? Can help in that conversation. But yeah, this is still a dilemma for us as well.
Just to follow up to that, as we do take more of these patients, we've certainly noticed a higher rate of intracerebral hemorrhage post-op, and have been called into question by some of our neurology or neurosurgery colleagues that maybe aren't as sort of up to date maybe they need to read your talk or listen to your talk. But we're dealing with that side of it where people outside of the field are concerned that hey, this is a pretty horrible looking CT scan in an older patient or whatever. Are you dealing with any of that type of thing, or not really, just based on the data?
Yeah, I mean, our neuro ICU colleagues versus our stroke neurology colleagues, we're a little bit, our stroke neurologists are very data driven. Our neuro ICU, of course, we're more clinically having to deal with these patients. So there, we could see that not disconnect, but at least some different interpretation, right, of the data. And it's important to note that these outcomes are 90 days out. And so what they see on day 1 to day 7 or day 14 even or day 21 is not necessarily what you're going to find in 90 days. Now, the other problem is that most patients, even if they might become independent in 90 days, the families are not willing to put that much time and effort and wait for that, because it is a pretty miserable, existence in the near ICU for quite a long time. Sometimes they need PEG to intubation, extended intubation. I try to do many of these patients awake so that they don't have to get intubated, because getting extubated can be so difficult, but sometimes they have to be intubated. So, and then you're looking at long-term ventilation. And you don't know of those 10 patients, which 1 or 2 are going to become independent, right? So
Right.
you may withdraw on the 1 or 2 that might have been, and then now you've got 20, 30 patients in a row that are all having poor outcomes, right? So
Right.
so it's hard to see.
One final question, and then I'll give it back to Majid. Does the infarct location for a given aspect, does the infarct location influence your decision making? And do you think we're sophisticated enough or have the numbers with these trials to look at that? If I see certain parts of the brain, like Broca's area or the internal capsule, out, my neurosurgical brain is telling me there's a pretty good chance that person's not going to talk again. But a lot of our trials don't seem to be sophisticated enough to get that granular. Do you think there's room for AI or looking back at these trials and trying to kind of triage people? Maybe there's better lower aspects people to take, etc. Do you think there's any role for the location of the infarct and the side of the brain?
Absolutely. I mean, we know just from the vertebral-basilar, the posterior circulation, that small strokes, midbrain pons, these patients are not going to do well, right? Because that's very eloquent tissue. So just like that in the anterocirculation, I'm sure there's regions of eloquence that are going to really debilitate them, and that's why maybe some patients do well in this large core because you're actually saving the eloquent tissue. It's not the fact that you're saving a lot of volume of tissue. Or is there some other benefit of reperfusion that we just don't understand for neuroplasticity and rewiring, right? So that's one thing. I'm sure AI and understanding, what regions of eloquence are associated with good outcomes versus poor outcomes, with infarction of those regions will be important in this risk assessment and selection in the future. But even like looking at median muscle occlusion, sometimes, a left hemispheric M3, supplying Wernicke's, is something you'll chase, because it's just so devastating for the patient versus an M3 on the contralateral hemisphere. You're like median muscle occlusion with NIH, whatever, borderline, they're going to get some of that function back, So that's another way of thinking about it.
Thank you so much. We have one question here. It says, aspect has different shade of gray. So when would you say there's a poor aspect of 3 versus a good aspect of 3?
Yeah, sure. I mean, aspects of 3 in the basal ganglia, right? You can get, with basal ganglia infarction and, cortical. I mean, aspects of 3. So you're like 7 territories are out. Yeah. So I mean, I don't know. I mean, I think that comes to Dr. Monteith's question. Like, are there certain areas that are spared that are more eloquent and may warrant intervention versus those that may be infarcted, and so aspects of three. I mean, you're looking at only three territories that are still intact, right? And it's very unusual to have basal ganglia sparing and have the entire cortex gone, right? So more likely it's the basal ganglia gone and with some cortex sparing. So you're going to have three cortical areas maybe spared. What are those? What are the important ones? Certainly, speech and motor cortex. Some of the eloquent areas. So I think yes, there's something to be said about that. And it's hard to pick that up on a CT scan, right? Where's, are we spared in the motor, are we spared in Broca's and Wernicke's? But if we did have some type of co-registration prior, or AI-based information that could tell us that there's some sparing, or it's a perfusion abnormality, but it's not infarcted, or there's, I think that's why we should continue with advanced imaging, because all the data that it produces, it's not a big cost on time. And there's a lot of interesting studies that we can do with it.
So you're still doing advanced imaging. We still do it. We still make decisions based on it. But there's definitely folks out there that maybe disagree with that now.
We have had some of our stroke neurologists like, why are we doing this? It's wasting time. It's wasting, and they've come from other sites. And then I think most of the neurointerventionalists here, we prefer it. It's just, it gives us an extra piece of information. It's not a huge cost from a time perspective. That's not going to change anything because our labs, we're all getting ready. And then it also helps us, prognosticate, like I mentioned. It gives us some quality data on how we did, compared to what we expected to do. So just the automation of post-processing now, and the ability to send that information, wirelessly is so valuable to activate our teams and improve our stroke workflow and processes with that information. Often we know there's a LVO on the perfusion imaging before CTA is even done.
Totally agree. I think especially for the more distal occlusions, it can be super helpful to localize the territory.
Yeah.
All right, great. See. There's one more question if we have time. I think, how do you manage blood pressure after a large core thrombectomy cases?
Yeah, that's a good question.
HT, not sure what's HT.
Yeah, that's a very good question. Yeah, I've always, even in a small core thrombectomy, I've always brought the pressure down, after revascularization, especially like a TK3, a complete revascularization. I will often not remove my guide catheter from the ICA until the pressure is controlled, because usually we're augmenting in the beginning, or they're sometimes even self-augmenting at 160, 180, up to 200. And then once we've revascularized, I'll leave my guide catheter sheath in the IC just to prevent flow, to inhibit a little bit of flow until the blood pressure can relax down to under 140. And then I'll move my guide catheter into the common and into the groin. And for large core, even more, you're just more stringent about it. But I've always done that, so it's kind of my basic technique.
Okay, great. Thank you so much, Dr. Ansari, for joining us. Great talk.
That's my pleasure. Yeah.
Thanks, Samir. That was awesome. Compulsory viewing for fellows every July.
Appreciate it. Yeah.
And attendings as a freshers. Really appreciate it.
Awesome. Thank you again. Yeah, appreciate it.
Have a good day.
All right. Take care.
Bye-bye. Yeah, take care.